Good morning and thank you, sir. Today's topic is enteric fever, an old foe to remember. I will be discussing two short case histories, introduction to enteric fever, epidemiology, pathophysiology, diagnostic methods, and then management and vaccines. Case history 1. A 29-year-old female office clerk from Coroner presented to the local hospital surgical ward with fever, vomiting, and lower abdominal pain for 3 days duration, which was following consuming fruit juice from a stall. The ultrasound abdomen showed an inflamed terminal ileum. The appendix was not visualized, and the patient underwent appendicectomy the following day. On day 8, she was discharged after 4 days of IV ceftriaxone. She presented to us on day 13 with on and off fever since discharge with ongoing but reduced abdominal pain and diarrhea. The blood culture was taken and she was restarted on IV ceftriaxone. The typhoid SAT showed Salmonella typhi anti-H antibody 1 in 320. Salmonella anti-O antibody 1 in 320. And the blood culture is positive for Salmonella typhi. Case history number 2. A 26-year-old nursing officer, a resident of Coroner, presented with 5 days of fever and headache. There was no diarrhea, constipation, or abdominal pain at presentation. She consumed food from takeaway shops often. She had taken oral Comesclave and doxycycline at home. The patient undergoes evaluation for prolonged fever as an inpatient on day 11 and develops lower abdominal pain and diarrhea later. The typhoid SAT revealed anti-H antibody 1 in 160 and anti-O antibody 1 in 320. The blood culture is negative. The patient is treated with IV ceftriaxone successfully, and the repeat typhoid SAT after 10 days shows seroconversion. So, enteric fever is a systemic infection with Salmonella enterica serotype, formerly known as Salmonella typhi, and serotype paratyphi A, B, or C, with paratyphoid being a milder infectious disease. Therefore, I will be mainly concentrating on typhoid in this presentation. Salmonella are gram-negative, non-spore-forming, facultative anaerobic bacilli belonging to the family Enterobacteriaceae. The other non-typhoidal Salmonella are there as well, and they cause a mild gastroenteritis-like disease. Unlike most Salmonella enterica serovus, typhoidal Salmonella are human-restricted pathogens. Humans are the reservoir for both typhoid and paratyphoid fever. It is better to know about Salmonella typhoid bacterial antigens to better understand the vaccines as well as serological investigations. The BI polysaccharide antigen contributes to the virulence, and it is a capsular antigen and is contained in the vaccine. The O antigen is a somatic antigen and helps in serological differentiation. The H antigen is a flagellar antigen and stimulates the host immune response. Epidemiology, it is a significant public health concern in low and middle income countries, particularly in South and Southeast Asia and in some parts of the African continent. Though global estimates suggest a reduction in cases since 2000, the burden remains substantial. As of 2019, an estimated 9 million people will get typhoid and 110,000 people will die every year worldwide. In Sri Lanka, the highest number of cases are reported from 5 to 9 years of age, and 2/3 of cases were among 1 to 34 years of age. The high numbers of infections are reported from Vavuniya, Jaffna, Nuwara, Colombo, and Kekal districts. The scarcity of water is the main issue in districts located in the dry zone, and contamination of the natural resources is the main problem in the hill country where the most springs are. This is the data from the last 10 years in Sri Lanka. It is taken from the weekly epidemiological report. So when demonstrated in the graph, you can see that from 2015, there's a steady decline in the cases, and the cases have been lowest during the COVID era. While the cases up to the 3rd week of April, the available data, you can see that their cases have increased from 20 in 2023 to 78 in 2024. There had been an outbreak of typhoid in March and February this year, and currently it is slowly coming down back to normal. The pathogenesis of typhoid begins with the ingestion of organisms with contaminated food or water, as less as 1,000 organisms is enough to cause the disease. The incubation period is between 8 to 14 days. They survive exposure to gastric acid and reach the small intestine. They penetrate the mucous layer and enter the submucosa by phagocytic M cells in the epithelia paired patches, which are lymphoid aggregates in the terminal ileum. After crossing the epithelium, it is phagocytosed by macrophages. Salmonella survive in the macrophage by altering its outer membrane proteins, and then they disseminate throughout the body in macrophages via lymphatics and colonize the reticuloendothelial system, which is the liver, spleen, lymph nodes, and bone marrow. They enter the bloodstream via the thoracic duct and cause the first bacteremia during the incubation period. The salmonella proliferate and cause hypertrophy of the Peyer's patches throughout the lymphocyte recruitment in the Peyer's patches. Meanwhile, in the reticular endothelial system, they multiply and re-enter the bloodstream, causing secondary bacteremia, and which is in the febrile phase. Later, the gallbladder becomes colonized, and the bacteria are excreted in the bile and back into the intestine. And this may cause subsequent hypertrophy and necrosis of Peyer's patches and can lead to ileal perforation. Meanwhile, throughout the process, there is shedding in stool and transmission, and the cycle continues. Clinical features in the first week. The patient typically presents towards the end of the first week with malaise, myalgia, anorexia, nausea, or poorly localized abdominal pain. Initially, the fever is low grade, but it rises progressively to be high and sustained during the second week. A relative bradycardia with pulse temperature dissociation may be observed, and this is thought to be due to cytokine release causing vagal activation and activation of the cardiac pacemaker cells causing bradycardia. Adults often have constipation, while in children, diarrhea is more prevalent. The classic fever pattern known in typhoid is known as the step-ladder fever pattern. It is continuous fever, which at no point touches the baseline and increases by increments of 1 degree Celsius. And following effective treatment, the effervescence occurs gradually. Clinical features in the second week. Rose spots are branching erythematous maculopapular rashes 2 to 4 millimeters in diameter throughout, thought to be bacterial emboli, and even can be cultured. And they are found over the abdomen, chest, and occur during the second week of infection. Examination may reveal a coated tongue, tender abdomen, hepatomegaly, and splenomegaly. In a case series comparison done in the United States, between the years 1930 and 1980 show a reduction in the prevalence of splenomegaly from 63 to 10%, and the prevalence of rose spots dropped from 30% to 1.5%, and the changes are likely due to early antibiotic usage. Clinical features in the third week. The intestinal bleeding and perforation due to ileocecal lymphatic hyperplasia and necrosis of Peyer's patches may occur in around 1% of the cases and can lead to peritonitis and septic shock. The image shows longitudinal typhoid ulcers in contrast to the horizontal tuberculous ulcers, and you can see a typhoid perforation in the second image, which is again longitudinal. There are also reported cases of splenic abscess in Sri Lanka. Neurological manifestations. Headache is a frequent symptom and reported in 44 to 90% of cases. Typhoid encephalopathy has been observed in up to 17% of patients with an approximate mortality rate of 50%. In a randomized double-blind trial done in Indonesia with 38 patients, the use of IV dexamethasone as an adjunct to antibiotics shows some success with reduction in mortality rate up to 13%. Myelitis and meningitis have been observed but are uncommon. There is a reported case of neonatal meningitis due to Salmonella typhi in Sri Lanka. Diagnosis. Blood culture is the current standard diagnosis method. You should have high volume blood samples, 20 milliliters, 2 to 3 cultures taken to optimize the yield. Positive in approximately 85 to 90% of patients who present within the first week of onset. The overall positivity rate is 50 to 70% in patients. Bone marrow is the most sensitive diagnostic modality, and it is sensitive in around 90% of patients, yet rarely indicated in routine practice. It remains positive in as many as 50% of patients, even after 5 days of antibiotics. Stool culture is a sensitivity of less than 50% and is often positive from 3 weeks on. Often positive for 3 weeks. So the timing of the culture, the bone marrow is not positive usually during the incubation period, but is positive during the first week and afterwards. The blood culture is most positive during the incubation period and the first week, and the urine culture is usually positive by the second or third week and is limited sensitivity from 25 to 30%. Serological tests. The Vital test, which was previously widely used, has limited clinical utility in an endemic area. When paired with an acute and convalescent sample 10 to 14 days apart, if it demonstrates a four-fold rise, it is taken as positive. The sensitivity is 70 to 80%, although the specificity is low, 40 to 50%. To get some idea about the interpretation, the O antigen, if it's positive more than 1 in 160, it may denote an active infection. The H antigen, if it's more than 1 in 160, it may denote a past or immunized infection. The H antigen is less specific, and the H antigen rises late and vanishes late as well. A rising titer of fourfold is taken as a diagnostic test. Other serological molecular tests, the rapid antibody-based test only has moderate diagnostic accuracy, and it has an overall average sensitivity and specificity between 70 to 80%. And there are newer approaches studied with serum IgA against hemolysin E, and they seem promising. PCR has limited activity in most studies with low concentration of bacteria during secondary bacteremia, and it is not widely available. So management includes antimicrobial therapy, supportive care including hydration, antibiotics, and monitoring for complications such as ileal perforation and peritonitis. Antimicrobial therapy, the empiric therapy is IV ceftriaxone, 2 grams daily, 7 to 14 days. If IV ceftriaxone is unavailable, cefotaxime is a reasonable alternative. If suspecting resistance for IV ceftriaxone, such as in a patient with travel to Pakistan or Iraq, a carbapenem such as meropenem can be used empirically. So this is the fever chart of the first patient I described. So typhoid has a particularly slower time for defervescence. You can see that from day 1, the CRP has dropped from 90 to 39 by day 6, but still the patient is having high fever spikes. And by day 8, the CRP is 23, but still the fever spikes are going on. And the defervescence occurs only by day 10. This is the second patient I had mentioned. Again, the fever was ongoing until day 8. Regarding antibiotic resistance, fluoroquinolone resistance occurs in many parts of South Asia. Over 80% of Salmonella typhi isolated are now not susceptible for fluoroquinolones. Less common in other parts in the world, including African continent. In fluoroquinolone susceptible infections, oral or IV ciprofloxacin or levofloxacin are effective. Norfloxacin is poorly absorbed and should not be used. Resistance to other agents. Ceftriaxone resistance is high in Iraq as well as Pakistan and has rising trends in Asia, and generally susceptible to azithromycin and carbapenems. Azithromycin resistance is growing number in South Asia. Multi-drug resistant strains such as resistant to ampicillin, trimethoprim, sulfamethoxazole, chloramphenicol are prevalent in Asia, Africa, and Middle East. The worrying extensively drug-resistant strains are strains that are resistant to 5 antibiotics, including ampicillin, trimethoprim, chloramphenicol, fluoroquinolone, and a third-generation cephalosporin. There was the last breakout in Pakistan in 2016 with more than 5,000 cases reported by the end of 2018. There is a continued high risk of extensive drug-resistant cases in Pakistan, and there have been imported cases from other countries from Pakistan as well. And this is treated with carbapenem such as meropenem, 1 to 2 grams, 8 hourly. These infections are often susceptible to azithromycin as well. Severe systemic illness with neurological symptoms. Clinical features such as obtundation or coma can occur, and an adjunctive IV dexamethasone 1 milligram 6 hourly is suggested. 1 milligram per kilogram 6 hourly is suggested. A randomized prospective double-blind study performed in Indonesia in 1980 among 38 adults and children. High-dose dexamethasone treatment reduced mortality compared to chloramphenicol alone. 10 versus 55% without increasing the rate of carriage or relapse. Management of iliac perforation. Prompt surgical intervention with emergency laparotomy is necessary. The best surgical procedure appears to be a segmental resection of the involved intestine when possible. Broader antimicrobial coverage with metronidazole for anaerobic cover is necessary. Even with surgery, mortality rates of 14 to 34% has been reported in the case series. A relapse can occur in immunocompetent individuals, typically occurs 2 to 3 weeks after resolution of fever, and should be treated with an additional course of antibiotic guided by the susceptibility testing. Usually, the isolate has the same susceptibility pattern as the initial testing. Post-acute stool shedding, up to 10% of untreated individuals shed bacteria in their stools up to 10 months post-infection. With antibiotic treatment, up to 5% individuals continue to shed Salmonella typhi 30 days after onset of fever. Screening is warranted for individuals at increased risk of transmission to others, such as food handlers. Samples are collected 1 week after discontinuation of antibiotics and at least 1 month after illness onset, with 3 source samples, each collected 24 hours apart. If the cultures are positive, repeat culture should be performed monthly until there are 3 consecutively negative samples. Chronic carriage is defined as an excretion of the organism in stool for more than 12 months post infection. The rates range from 1 to 6%. The risk factors include older age, female gender, gallbladder abnormalities, and gallstones. And it's screened with 3 stool samples 24 hours apart. Estimated sensitivity is 70 to 80%. The risk factors for chronic urinary carriage include kidney stones and schistosomal infections. The management includes, for patients with fluoroquinolone non-susceptible isolates, one of the below can be used: high-dose amoxicillin 3 grams in divided doses for 6 to 12 weeks, or trimethoprim 840 milligrams twice a day for 3 months. For fluoroquinolone susceptible patients, you can use ciprofloxacin 750 milligrams VD for 4 weeks duration. This approach is supported by a 2022 systematic review, including 8 studies and 126 patients. Association with gallbladder carcinoma and chronic infection with Salmonella typhi. A meta-analysis of 17 case-controlled and cohort studies suggests association between chronic Salmonella typhi carriage and elevated risk of gallbladder carcinoma. Multiple case-control studies have tested GBC cases against gallstone controls and population-based controls and have performed culture and quantitative polymerase chain reaction for the subset with available bile, gallstone, tissue, and stool samples and have found the same results. The exact carcinogenesis mechanism of Salmonella typhi is not much clear, but studies suggest carcinogenesis due to relapse of effector protein molecules secreted into the host cells and causing host cell DNA damage. The outcomes of enteric fever. Effective antibiotic therapy has dramatically impacted the outcome of enteric fever. The mortality rates in pre-antibiotic era versus post-antibiotic era is around 15% versus 1%. Typhoid vaccines. There are 3 typhoid vaccines approved by WHO. The first one is the unconjugated VI capsular polysaccharide vaccine for parenteral use, which is available in the Sri Lanka at the moment. And it is licensed for travelers from non-endemic countries. And it can be used from age 2 years above. It is given as an IM single vaccine followed by booster 2 yearly. And it should be started 2 or more weeks before travel. And the efficacy is 50 to 80%. The typhoid conjugated vaccine, which is used in India, can be used from 6 months and above. And the IM injection is given as a single dose and provides protection for more than 4 years. And is recommended to be used in endemic areas by the WHO since 2017. And the efficacy is between 79 to 85%. There is also oral live attenuated vaccine, but it can be used only after the age of 6 years. It is a capsule, and the traveler should complete the vaccination regimen 1 week before potential exposure, and the efficacy is 50 to 80%. So in Sri Lanka, the vaccine currently used by the Ministry of Health is the unconjugated VI polysaccharide vaccine I had mentioned first. and a single dose is given to the deltoid region, and it gives a protection for a period of 3 years and needs a booster subsequently. And it is administered to high-risk category food handlers. And after scrutinizing local and international reports, the epidemiology unit suggests to administer vaccine only for high-risk groups in high-risk areas such as Colombo, Kegol, Jaffna, Baunia, and New Delhi. Prevention includes food and water safety. Prevention of contamination of water sources is carried out, especially in relation to water projects, public and household wells. Practice of hand and food hygiene is educated and promoted. A register of food handlers in the PHI area is maintained, and they are vaccinated once in 3 years. So take-home messages are: typhoid is an infectious disease preventable through good sanitation. It should have high degree of suspicion when a patient presents with prolonged febrile illness, even without diarrhea. 2 to 3 high-volume blood cultures should be taken to increase the diagnostic yield. IV ceftriaxone is a recommended empirical antibiotic. Defervescence takes time, therefore should not hasten the change of antibiotics when the patient has improved clinically and biochemically and only fever persists. The typhoid vaccination is considered for high-risk group in endemic areas of Sri Lanka. These are my references. Thank you.